Welcome to GE Healthcare's webinar series on lung protective ventilation during surgery. I'm Lisa Nolan, Global Clinical Insights and Education Leader for Anesthesia and Respiratory Care. Lung protective ventilation strategies have moved from the intensive care unit to the operating room. They are being adopted by many institutions across the globe looking to reduce post-operative complications and length of stay. GE Healthcare's Anesthesia and Respiratory Care Division has partnered with 7 global thought leaders in anesthesiology to host a lung protective ventilation forum. The forum was a structured literature review and scientific discussion with the goal of reaching a consensus on a set of lung protective ventilation approaches for surgical patients. During this series, you will hear from 2 of those thought leaders, Dr. Emmanuel Foutier from University Hospital of Clermont-Ferrand in France, and Dr. Christopher Young from Duke University Medical Center in the United States. The 2 will discuss the use of lung protective ventilation during the induction, maintenance, and emergence phases of anesthesia. The recommendations discussed are published in the December 2019 issue in the British Journal of Anaesthesia. In the previous video, you heard from Dr. Emmanuel Foutier on lung protective ventilation during the induction phase of anesthesia. In the next video, you will hear from Dr. Christopher Young on lung protective ventilation during the maintenance phase of anesthesia. Thank you for joining.
Hello, my name is Christopher Young, Professor of Anesthesiology at Duke University Medical Center in Durham, North Carolina. In a previous video, Dr. Foutier examined the role of lung protective ventilation during induction of anesthesia. We will pick up the same case and look at LPV during anesthesia maintenance. You may recall the patient is a 59-year-old woman with a BMI of 31.2. Her medical history was significant for ovarian cancer, hypertension, and type 2 diabetes. She's undergoing laparoscopic oophorectomy and hysterectomy scheduled for 3 hours in Trendelenburg position under balanced general anesthesia. Induction of anesthesia was accomplished with 100% oxygen at 6 liters per minute flow until oxygen saturations reached 100%. The patient was initially ventilated in the operating room with volume-controlled ventilation using a tidal volume of 450 milliliters, a respiratory rate of 14 breaths per minute, PEEP of 5 centimeters water, and an FiO2 of 60%. At the start of the case, the peak pressure was 30 centimeters water with a plateau pressure of 14 centimeters water. Compliance was measured at 50 mLs per centimeter water, and O2 saturation was 98%. After pneumoperitoneum insufflation and Trendelenburg positioning 30 degrees, head down, peak pressure rose to 35 centimeters water, and plateau pressure rose to 20 centimeters water. Measured compliance was down to 30 mLs per centimeter water, and O2 saturations fell to 89%. Outside of changes to ventilation status, the patient is hemodynamically stable. In this case, what respiratory mechanics should be monitored on all controlled mechanically ventilated patients during surgery? Option A, plateau pressure only. B, plateau pressure, driving pressure, and compliance. C, airway resistance, compliance, and auto PEEP. Or D, compliance only. The answer is B, plateau pressure, driving pressure, and compliance. Driving pressure, or the difference between plateau pressure and end expiratory pressure, is the pressure change that occurs with each mechanical breath. Recent studies suggest that limiting driving pressure to less than 14 centimeters water is associated with fewer pulmonary complications in OR and ICU patients. This figure comes from a meta-analysis of patients undergoing mechanical ventilation in the operating room. An increase in the level of PEEP that resulted in lowering of the driving pressure reduced the risk of PPCs in the second panel, while an increase in driving pressure occurring with increased PEEP, fourth panel, resulted in more postoperative pulmonary complications. For this reason, it is recommended to measure driving pressure in addition to compliance and plateau pressure in all mechanically ventilated patients. The recommendation and statement we made was, in addition to standard monitoring, dynamic compliance, driving pressure, and plateau pressure should be monitored on all controlled mechanically ventilated patients. Consensus 100%, quality of evidence low, Strength of recommendation, strong. Moving on to question number 2. Based on the information in this scenario, would you consider performing a recruitment maneuver? A, yes. B, no. C, not sure. The correct answer is A, yes. In this figure, patients who received a recruitment maneuver, shown by the dotted line, demonstrated significant and sustained improvement in respiratory system compliance compared to those who did not receive a recruitment maneuver. The recommendation we reached was continuous hemodynamic and oxygen saturation monitoring is recommended before and during recruitment maneuvers. Ensure adequate hemodynamic stability prior to performing a recruitment maneuver, and avoid recruitment maneuvers when contraindicated. Consensus 100%. Quality of evidence high. Strength of recommendation strong. Question 3. In the scenario, the patient's oxygen saturation dropped to 89%. What intervention, if any, would you take? A, increase the FiO2 to 80%. B, increase the PEEP without a recruitment maneuver. C, perform a recruitment maneuver, then go back to a PEEP of 5 centimeters water. D, perform a recruitment maneuver and increase the PEEP. The correct answer is D, perform a recruitment maneuver and increase the PEEP. Each of these 3 panels shows 2 superimposed respiratory pressure volume loops. The top left shows that applying PEEP without a recruitment maneuver does not improve compliance. Likewise, the top right panel shows that a recruitment maneuver without increased PEEP also does not improve compliance. The bottom panel shows that the combination of a recruitment maneuver and PEEP is effective in maintaining improved respiratory system compliance, that is, improved lung volume for a given airway pressure. Our statement is, decreasing compliance caused by surgical and anesthesia factors such as pneumoperitoneum, positioning, and circuit disconnect should be treated by appropriate interventions. Individualized PEEP can prevent progressive alveolar collapse. Recruitment maneuvers can reverse alveolar collapse but have limited benefit if not followed by sufficient PEEP. Consensus, 86%. Quality of evidence, high. And this is a statement. Question 4. How should a recruitment maneuver be performed on this patient? A, manual bag squeeze. B, CPAP by the ventilator. C, stepwise increase in pressure and PEEP. Or D, increasing the tidal volume at a fixed higher PEEP. The correct answer is C, stepwise increase in pressure and PEEP. The manual bag squeeze is not recommended because airway pressure can approach 0 during the transition back to the ventilator circuit, resulting in loss of alveolar recruitment. When an alveolar recruitment maneuver is accompanied by increased PEEP, improvements in compliance can be maintained. In the randomized controlled trial pictured here, a lung protective ventilation strategy with lower tidal volumes, 10 centimeter water PEEP, and recruitment maneuvers improved measures of postoperative pulmonary infection, arterial oxygenation, and pulmonary function tests. There was no increased incidence of intraoperative complications or non-pulmonary organ failures in the group receiving recruitment maneuvers and PEEP. Our recommendation is the bag squeezing recruitment maneuver should be avoided in favor of a ventilator-driven recruitment maneuver. Consensus 100%. Quality of evidence very low. Strength of recommendation weak. Question 5. Based on this scenario, what would be an appropriate plateau pressure and number of breaths for a recruitment maneuver? A, plateau pressure 30 to 40 centimeters water for 3 to 6 breaths. B, plateau pressure 40 to 50 centimeters of water for 3 to 6 breaths. C, plateau pressure greater than 50 centimeters water for 3 to 6 breaths. Or D, plateau pressure 10 to 20 centimeters water for 3 to 6 breaths. The correct answer is B, plateau pressure 40 to 50 centimeters water for 3 to 6 breaths. While a number of methods are available to produce alveolar recruitment, the panel of experts was unanimous in recommending the avoidance of the bag squeeze technique. Depending on the patient's BMI, plateau pressures of 30 to 50 centimeters water are needed for effective recruitment. In this study, 16 patients undergoing neurosurgical or laparoscopic surgery had an average BMI of 26 kilograms per square meter. Lung computed tomography was used to measure the extent of atelectasis. The horizontal bars represent the average area of atelectasis. 40 centimeters water pressure reduced overall alveolar collapse more than pressures of 30 centimeters or less. Pressures of 50 centimeters or more may be needed in higher BMI individuals. Our recommendation is recruitment maneuvers should be performed using the lowest effective plateau pressure, 30 to 40 centimeters water in non-obese patients and 40 to 50 centimeters water in obese patients, and the shortest effective time or fewest number of breaths. Consensus 100%. Quality of evidence low. Strength of recommendation weak. Question 6. In this scenario, what is the recommended PEEP level following the recruitment maneuver? A, remain at 5 centimeters water. B, increase PEEP to 10 centimeters water. C, increase PEEP to 15 centimeters water. Or D, individualize PEEP setting to maintain improving respiratory mechanics and O2 saturations. The correct answer is D, individualize PEEP settings to maintain improving respiratory mechanics and O2 saturations. PEEP should be titrated to the highest level of compliance. Factors such as high body mass index, peritoneal insufflation, and head-down positioning can reduce compliance and may require additional recruitment maneuvers and PEEP. In this study, PEEP levels were down titrated by 2 centimeters water, starting from 20, until a reduction in compliance was noted, here going from 10 to 8 of PEEP. Subsequently, a second recruitment maneuver to 20 centimeters water was performed and PEEP set to 10, the level where the highest compliance was noted. This PEEP titration can be repeated whenever compliance decreases. Our recommendation is PEEP should be individualized following a recruitment maneuver to avoid both alveolar overdistension and collapse. Consensus 71%. Quality of evidence low. Strength of recommendation weak. Our statement is decreasing compliance caused by surgical and anesthesia factors such as pneumoperitoneum, positioning, and circuit disconnect should be treated by appropriate interventions. Individualized PEEP can prevent progressive alveolar collapse. Recruitment maneuvers can reverse alveolar collapse, but have limited benefit if not followed by sufficient PEEP. Consensus 86%. Quality of evidence high.
Thank you for joining the webinar series on lung protective ventilation during surgery. For more information, please contact your local GE Healthcare sales representative.